Welcome to our video on infectious diseases of pregnancy. And here we're focusing specifically on acute pyelonephritis, group B strep, and chorioamnionitis. Let's get started. So here's that list of those things that we're going to talk about. So we're going to start with acute pyelonephritis. Acute pyelonephritis is an upper urinary tract infection that involves the kidneys. The risk factors for acute pyelonephritis during pregnancy include the history of diabetes mellitus, asymptomatic bacteria, and age less than 20 years. Okay, now the reason that diabetes is a risk factor is because diabetes results in glucosuria, which allows bacteria to grow in the urinary tract. Asymptomatic bacteriuria, on the other hand, means that there are bacteria in the urine which might ascend up to the kidneys, causing acute pyelonephritis. And you may remember that asymptomatic bacteriuria is really not something that you treat in most patient populations, but pregnant patients are one of the main exceptions. If you ever see asymptomatic bacteriuria in a pregnant patient, you need to treat it because you're so worried about acute pyelonephritis that you want to treat it. And another complication of just having acute pyelonephritis is requiring preterm delivery. So don't let this go untreated. And the common pathogens causing acute pyelonephritis include E. coli, which is the most common cause. There's also Enterobacter, Klebsiella, and group B strep. Okay, what are the fetal complications of acute pyelonephritis? Well, being born early is not healthy for the fetus, and also being born at a low birth weight, which is really a product of preterm birth. So what do you do about it? Well, what you do is you administer IV ceftriaxone, and if the patient is afebrile for 48 hours after starting ceftriaxone, then you can actually transition down to oral cephalexin. So the idea is that you're doing a cephalosporin. You start with an IV cephalosporin, ceftriaxone, and then you move down to oral cephalexin. And the total duration of antibiotic therapy for this acute pyelonephritis should be from 5 to 14 days. Now, it's important to know that the risk of recurrence for pyelonephritis in pregnancy is actually between 6 to 8%. And to prevent it, you've got a couple of options. So one, you can do daily antibiotic prophylaxis at a low dose. So you could choose cephalexin or nitrofurantoin. And then what you would do is during the third trimester, usually at the beginning of the third trimester, you'd do another urine culture just to ensure that your antibiotics are working effectively. And if not, then you can adjust what you're prescribing, you can adjust the dose, and just change the coverage so that you're adequately treating the bacteria. Now, another option is to not do any prophylaxis, but then just do monthly urine cultures to ensure that everything's okay. And then, of course, if anything does grow, then you would treat. Okay, now let's move on to group B Streptococcus. So group B strep is gram-positive, and it colonizes the vagina, and it's actually the most common cause of three things in the neonate: sepsis, meningitis, and pneumonia. And it can also cause chorioamnionitis during pregnancy. So after delivery, the patient can have sepsis, meningitis, and pneumonia, but even before that, the whole pregnancy can be complicated by chorioamnionitis. So group B strep is bad. And here you can see group B strep cultured on blood agar. And you can actually notice these beta hemolytic colonies. So now let's discuss how you prevent this from occurring. So first, every woman should undergo antenatal screening via a rectovaginal swab at 35 to 37 weeks of gestation. So let's talk about the indications for the intrapartum prophylaxis. You do this through IV penicillin or ampicillin. Now, if the woman has had a prior infant with early onset neonatal group B strep infections, then she doesn't even need the rectovaginal swab. You're just going to decide, okay, that's so high risk because you've had this with one of your newborns. We're going to just give you prophylaxis even without doing the rectovaginal swab. Additionally, if she has had group B strep bacteriuria or a UTI during her current pregnancy, then she also doesn't need a swab. You're just going to give her prophylaxis. So both of those are very intuitive. Like if you already know the risk and you're just worried about this patient, then you really have this low threshold for wanting to just give prophylaxis for group B strep. But now let's say that you get a patient that has a fever and you don't know the group B strep status. Well, in that case, you think, okay, well, the patient has a fever. We don't know yet. The culture hasn't come back yet for group B strep. And this is preterm labor. She's starting to go into labor now. So we got fever, preterm labor, and there's prolonged rupture of membranes for greater than 18 hours, then you're concerned. Any one of those circumstances, even if you don't know the group B strep status, would warrant giving penicillin or ampicillin IV. So you can think of a patient coming in, preterm birth, you think, oh my gosh, this is early, this is a preterm delivery. And that in and of itself, assuming she hasn't had a rectovaginal swab up to this point, then that in and of itself would warrant giving this prophylaxis. And then the rupture of membranes idea just means that if it's taking so long for the membranes to rupture, that's a long enough period of time in which you're worried that the fetus could become infected with group B strep if there was colonization of the bacteria inside the vagina. And then, of course, anytime group B strep comes up positive on the rectovaginal culture, you're going to give prophylaxis. So now let's do a question to apply what you've learned so far. A 27-year-old G2P1 female comes to the physician at 32 weeks of gestation for a routine prenatal visit. Her previous pregnancy was complicated by neonatal group B Streptococcus pneumonia. The physician tells her that she will need intrapartum penicillin prophylaxis for group B strep without the need for undergoing a rectovaginal swab in the next few weeks. What is the most likely rationale behind administering intrapartum penicillin to this patient without the rectovaginal swab? Okay, so this patient had a prior history of neonatal group B strep. So her first child had pneumonia with group B strep. And that alone is an indication for intrapartum penicillin prophylaxis. So remember, that was one of the reasons that you can forego the rectovaginal swab and just give the prophylaxis. And the rationale or the reason is that the patient is already at such a high risk for having group B strep vaginal colonization that you don't want to take any chances at this point. So the risk of giving her a prophylaxis is not nearly as much as the risk of the infant or neonate developing a group B strep complication. Now let's wrap up with chorioamnionitis. Chorioamnionitis is also known as an intraamniotic infection. So let's talk about the risk factors first. So risk factors include a prolonged rupture of membranes greater than 18 hours. So as you can see, this 18-hour mark is pretty important. After that point, there's high risk for infection with group B strep, or in this case, chorioamnionitis. Another risk factor is PPROM, which is preterm premature rupture of membranes. And then, of course, prolonged labor. So anytime there's this protracted labor, whether it's the membranes aren't rupturing or the labor itself is just long, even though there was a rupture of membranes, then there's risk of infection. So the idea is that the longer the fetus stays in the uterus during labor, the higher the chance that bacteria will ascend through the cervix and infect those gestational membranes. Now, another reason why a protracted labor can increase risk of infection is during those circumstances, you often apply or employ an internal fetal monitoring device. Or at the very least, you're doing repetitive vaginal examinations as you wait for that fetus to descend and the cervix to dilate. So those actions that you're doing to try to take care of your delivering patient are actually increasing the opportunity for bacteria to be introduced to the uterus. So finally, the presence of a genital tract infection, such as chlamydia or gonorrhea, especially if it's present during the labor, can obviously increase the risk of chorioamnionitis if those bacteria are allowed to ascend into the uterus. And what would increase the opportunity for those organisms to ascend up into the uterus? Well, a long, protracted delivery. So hopefully these ideas of what can cause or increase the risk of chorioamnionitis are pretty intuitive. Just long labor, lots of examinations and stuff going in there, and then any existing genital tract infections. Okay, now let's focus on how you diagnose and treat this condition. So to make the diagnosis, you need a few criteria. So the first is the mother needs to have a fever. And then there's 3 other things. Only one of them needs to be present, but you need one of these in combination with that fever to diagnose chorioamnionitis. So let's talk about these. So purulent amniotic fluid, and that's fairly intuitive. We're talking about the amniotic fluid being infected, like inflammation of the chorioamnion. So if it's purulent, then that checks the box. And if the mother has leukocytosis, that can also check the box. Also, if the fetus is experiencing tachycardia, specifically 160 beats per minute or greater, then that in combination with the maternal fever can diagnose it. Okay, so you've got this patient in front of you, and they've been diagnosed with chorioamnionitis. What do you do? First thing is you need to deliver urgently. And then secondly, which is probably the most intuitive aspect of this, you're going to apply broad spectrum antibiotics, such as ampicillin and gentamicin. And this is interesting because we don't actually know the pathogen that's causing the infection. It's like we said before, it could be chlamydia or gonorrhea. It could be any number of things, but you're not as concerned about getting the precise pathogen right, at least not in the beginning. Once you diagnose chorioamnionitis, just give them broad spectrum antibiotics and deliver the fetus. And that concludes our section on acute pyelonephritis, group B strep, and chorioamnionitis.